Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
This is Lindsay Smith-Rogers. Today, the importance of starting treatment for opioid addiction in the emergency department. Arianna Campbell is an emergency department and addiction medicine physician assistant at Marshall Medical Center in Placerville, California. She's also the co-founder of the Bridge Center at the Public Health Institute, a program that helps emergency departments around the country build addiction treatment programs. She speaks to Dr. Josh Sharfstein about how this work has evolved over the last decade to become the standard of care. Let's listen.
Arianna Campbell, thank you so much for joining me today on Public Health on Call. How are you?
I'm doing great. Thank you so much for having me.
I want to talk to you about an effort that I know you have personally been deeply involved with, which is getting emergency departments to provide more treatment for people with opioid addiction.
Yeah, this has been a big goal for a long time, just to have treatment for opioid use disorder as a tool in my toolkit. And a lot of this stems from feeling somewhat helpless or just not having those tools for 17 years of my 25-year career, and then making practice change, which, quite frankly, wasn't that challenging, and providing this as just a part of practice. My daily routine when I see a patient, just as if they had high blood pressure, and I would address that. If there's any indications of opioid use disorder, or if that person feels safe to disclose that to me, it's something that I can help them with.
So take me back before you started offering treatment. What was that like? They came to see you for something else, and how did you experience that?
There was a lot of unsaid things. So there would be, I think, on my part, a suspicion, and then a feeling that this person wasn't disclosing something to me. In fact, I think it's always, oh, they're lying to me. They're not telling me that they're using opioids in a non-prescribed way, or they're falling asleep and they told me they don't use drugs, and feeling this disconnect actually with the patient, which actually makes me feel uncomfortable. In the emergency department, I need to make really quick connections with people and establish rapport and trust rapidly. And when you get that disconnect from the start, it's uncomfortable and you feel like you're not addressing the elephant in the room.
And how did that begin to change for you?
I was asked to attend a meeting, as I think a lot of us, you attend a meeting, and I had a moment of self-reflection where somebody was asking if I would start a medication, buprenorphine, if somebody was in opioid withdrawal. And I had a lot of misinformed ideas, actually. I just didn't have a lot of training in this. And when somebody proposed that to me, I actually didn't even think it was legal. And of course it was. It's the standard of care. It's a recommended treatment. And once I took a step back and looked at the overall picture, which was, what am I doing right now for people with opioid use disorder that I am so proud of, that I wouldn't make a practice change? And of course, that was nothing. I was sending people to non-evidence-based treatment. I was sending people to places that wanted them to pay a lot of money to stay for 3 months and may not have been prescribing medications and may have been putting them at risk of overdose when they left. I live and work in a small community, and I would actually get feedback that the information I was giving people wasn't helpful, that they were having trouble accessing the kind of care that I was trying to connect them to.
So you go to this meeting and you hear, well, actually, there's a treatment you can provide in the emergency department, and you begin to offer that treatment. You get trained, you begin to offer that. How does that change the dynamic that we were talking about before for patients who are showing up?
Well, I had a moment of humility in practice in that I thought, how did I not know that this existed? And then it really changed my interaction with people who use drugs. It's like I opened a small door into what's possible when you make this, practice change. And my patients started talking to me about a lot of things. In fact, many people disclosed that they had never talked to a healthcare professional about their substance use. They didn't feel comfortable telling somebody because they thought they would be mistreated. And once they realized that as part of their visit in the emergency department, we could talk about this and provide a reasonable set of options. It just completely changed it, not just my practice, but it changed, I think, the view of our emergency department, even in the community.
And did it change the view of the staff towards the patients?
That's a great question. That happened through time. So initially, I'll admit, I didn't tell many nurses that we were doing this or our staff. I was actually afraid somebody would tell us we couldn't do it. And I knew it was the right thing to do. And that was a mistake because I put signage in the emergency department in like the lobby in the waiting room. And when I did that, a nurse came to me and said, "Wait, what are we doing?" And I explained it. And there was also, coming from the same place, there was a lot of misinformation that, people thought, are we just substituting one opioid for another? Are we enabling this behavior? And this is from just an antiquated set of ideas that wasn't based in medicine. And I knew I had a lot of work to do, actually. We did a stigma intervention in our hospital that made a massive difference in people's understanding of what we could offer, what we could do, and why it mattered.
So you're now treating patients and you realize that what you've gone through, the process you've gone through, can actually help other emergency departments change too.
Yeah, I think, I stood this program up in a rural hospital, community hospital, single hospital system. And I don't think I realized it was supposed to be really hard. So then when I realized that there was a lot of pushback, there was a lot of people saying that this can't happen anywhere, I think I took that as a challenge maybe, that I actually thought this could happen anywhere. We started this prescribing in a matter of 4 to 6 weeks of just learning about, what we could do and how we could change that. And now it's on a quality improvement spectrum. We're always looking to improve our program. But we started working in other hospitals and realized there's some resources that can be helpful. We realized that we could teach people how to do this. We could create champions who can lead these efforts and that it would work. And then we worked with urgency, realizing, really the massive scale of the overdose epidemic, and that if we worked with urgency, we could create a whole system. And this is the dream, that you see an H on the freeway, and you, just like if you're experiencing chest pain, and you would say, I should go to a hospital because I'm really worried that I'm having a heart attack, that you could see an H on the freeway, and you could go to that hospital and have a reasonable expectation of receiving high-quality, evidence-based care for opioid use disorder and opioid withdrawal.
Since you started doing this work with other hospitals, how many hospitals have you been engaged with?
276 in California. Now we've worked deeply in more than 17 states, and that those numbers continue to grow. So more than 300 hospitals total and growing.
That is a large number of hospitals. That must mean thousands of patients.
Yeah, hundreds of thousands of patients, actually. It can be done. It can be done rapidly. And, emergency clinicians, I think, are naturals to make practice change quickly. We're asked to do that often because the work that we do, there's life and death consequences, as with what many of us do, but in real time. And so I think we are able to make change pretty rapidly to meet the standards that are set in communities and to really meet the demands of high-risk patients, people who are experiencing high-risk conditions.
So when you go into a hospital that is just signed up to start to do this, you must run into some resistance sometimes.
Yeah, a lot of the resistance is that we're too busy, and we're all too busy. I am too busy. I am seeing people in the waiting room. I'm seeing people in triage. I am making up rooms to see my patients. And what I think is really important is that when you do this and you start adopting this practice, you're actually addressing some underlying conditions that make a difference for people so that they don't need to come back over and over again for the same reason. We're addressing sort of a root cause of many of the medical challenges that people face. And at the same time, we are kind of putting the underlying issue on the table. We're making it safe for people to disclose a highly stigmatized condition. And so where somebody may come in saying they have abdominal pain, And that means I'm going to do a lot of things that, including a CT scan, something that is a lot of radiation, right? And if they feel safe just telling me that they're in opioid withdrawal, I can very easily treat that with a medication that dissolves under their tongue. And they don't need a lot of these other interventions because we just created a safe space to have a therapeutic relationship and to discuss what's really going on. So it's actually the opposite. When people say, but I'm too busy, I actually often say, but you're too busy not to make this practice change, actually. And that's what we found.
Let me ask you about evidence. You have worked in all these different hospitals. How can you tell you're making a difference?
Well, we track it, as any good public health professional, we look at the data. So this is what was really surprising to me. You only know the data that you are looking at and collect. And we were never looking at or collecting data on opioid use disorder. And we actually weren't doing that because people weren't making the diagnosis. And we just didn't know to look at this. So, in terms of what we've done in the state of California, we've been looking at overall data, and you can do this from your local hospital to like a statewide initiative, right? So let me describe this in my local hospital. We just look at how much buprenorphine are we prescribing? Because if there's a drop in buprenorphine prescribing, this is a medication to treat opioid use disorder, then we know that there may be some barriers, there may be some gaps in education, because we know that there are a lot of people out there with opioid use disorder. So we start looking at why. We also look at the variability. Who is getting buprenorphine? Are there people who are invisible in our communities? And then we look at other things like how we can affect, for example, readmissions. Are people leaving without finishing treatment? Are people needing to be readmitted because we didn't provide them the right medication at the right time? So we've really put this into a category like other high-risk conditions on a local level. And we look at our data, we look at it monthly, and then we look for any change that means our system could be better. We also look at follow-up rates. Are people making it to treatment from our emergency department? We've maintained very high follow-up rates. And then on a statewide level, we had ways people were reporting it for a long time, but we found out good objective data. Watching our PDMP, watching how much buprenorphine is being prescribed and by who, I think is really important on a statewide level.
That's great. A lot of different measures. You recently had a major study published.
Yeah, we just published some great researchers published on our program in JAMA a few weeks ago. That was led by Annette Decker. And that paper showed that just emergency department clinicians giving prescriptions for buprenorphine makes a big difference. So we found that 1 in 3 people who were given a prescription for buprenorphine from the emergency department received a second prescription, right? So this is a big deal because this medication can, over a period of time can cut a person's risk of dying in half. So, any period of time in treatment with medications for opioid use disorder is a really good thing. And that 1 in 9 of those people actually had continuous treatment for 6 months. I mean, that's a really good number. If you think of, I initiate treatment for asthma, for emphysema, for diabetes, for, hypertension, high blood pressure, all sorts of medical conditions. And often people do face disruptions in treatment for a variety of factors. So these are pretty astounding numbers, actually.
So you've gone from not providing this treatment yourself for many years to providing it for your patients in a small emergency department, to sharing your knowledge with hundreds of other hospitals, to finding evidence that it's making a difference at a large scale. That's really remarkable.
Yeah, I would say it's, of course, my proudest work in medicine. If you asked me 10 years ago if I would be doing this, I could have never predicted that. But I think I saw a massive gap in medicine, this massive gap where we could be doing so much more. And then as the overdose crisis escalated, there's urgency associated with it. Why aren't we doing more when we have answers and we have tools? And then working through all of the challenges you had mentioned, different emergency departments come to us with different challenges of why this may be, why this is hard in their setting. Working through that and figuring out ways and doing it with urgency and doing it with creativity, I think that is that's the proudest work I've ever done in medicine. It's really been important and can impact whole populations. And that, I started thinking about things more from that public health, population health perspective. And I think this program, this project opened my eyes up to the impact we can have when you see a wrong and you work to right that wrong in medicine.
Arianna Campbell, thank you so much for joining me.
Thank you so much for having me. This has been fun. I appreciate you.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, Stephanie Desmond, and Grace Fernandez-Ciceri. Audio production by J.B. Arbogast, Michael Bonfils, Spencer Greer, Matthew Martin, and Philip Porter, with support from Chip Hickey. Distribution by Nick Moran. Production coordination by Catherine Ricardo. Social media run by Grace Fernandez-Ciceri. Analytics by Elisa Rosen. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.